Just a minute. Good afternoon, everybody. We weren't sure which direction to go in because this is a bit of a big room. So, but thank you everyone for coming for our didactic LGBTQIA+, belonging in a time of division. We have no disclosures. We do want to acknowledge, however, that members of the gender minority and sexual minority community are quite diverse, and so there's unique characteristics and considerations that need to be applied. We are faculty here of a combination of Emory University Emergency Medicine and also VCU, where I represent. As we go through, we're each going to introduce ourselves. So I'm Joel Mall. I'm a professor and vice chair of education at VCU. My pronouns are he, him. So as we all know, there is a time of division in the United States. A lot of that is fueled by attention to aspects having to do with sexual and gender minorities. Having said that, despite what the rhetoric and the things that we see in the media, a survey a couple years ago, actually from the bluest of states to the reddest of states, the majority of people still believed in having protections for LGBTQ+ people as far as their rights. So this is from a few years ago. Maybe that's changed, maybe it hasn't, but this is the most updated version. But certainly with a slew of laws and the rhetoric that's out there about LGBTQ+ and about trans especially, you know, 80% of people who are in the community feel less safe and certainly vulnerable because of the bans in gender affirming care and also some of the laws that have passed that, you know, even allow physicians to opt out of caring for anybody if it's not in their belief what their life is. So the thing to keep in perspective, if you're not a member of the gender or sexual minority community, is every day somebody comes to you as an emergency physician, they have to make the decision consciously, are they going to be their true and authentic self? Are they going to tell you who they are? Are they going to tell you those kind of realities? It's almost like they have to come out every time they come to the doctor. And if you know anyone who's ever gone through the come out process, it's quite personal and it can be something that's very emotional. So that's something that they want to talk about because ultimately you want to say when they come to the emergency room, is it okay for me to be in that emergency room? Are they going to take care of me in that ED because of the fact I need their help at this time in my time? So our learning objectives, as you can see, is to talk about common barriers faced by patients and obtaining health care. We want to apply some knowledge about providing health care for the LGBTQI+ population and mitigating disparities with some cultural humility. And we also want to demonstrate techniques to provide a safe and inclusive ED experience for members of the LGBTQI+ community. Our format you can see right here. I won't belabor the point since we lost a minute when the lights came bright. A little bit of shared experiences. I'm just going to start first. So a few years ago, I went to visit some friends with our husband in New York City. And of course I got appendicitis, right? You know, I always get sick or break a bone on vacation. Hopefully this is not considered vacation, so I'll be okay. But no, you know, this is New York City, so probably one of the more progressive cities in the United States when it comes to issues with sexual and gender minorities. However, I went to the emergency room. Of course, I was one of 3 people that had to go to the OR that night for appendicitis, confirming the rule of 3s, right? You know, we're all superstitious in emergency medicine. I was part of that. But however, you know, they said to my husband, they said, okay, we're going to take him up to pre-op. You need to go home. We'll call you if anything bad happens. Okay. I go up to the pre-op area and the guy who also has appendicitis and his wife are there. The other guy that has appendicitis and his wife are there. They're allowed to stay the entire time. Post-op, the wives were let back in the post-op. My husband never even got a phone call that I had finished the surgery, was alive. And this was not too long ago in a very progressive city. So it sees that there's kind of like, you know, I could tell you, it didn't really make me feel like I belonged. Okay.
Hi, I'm Kim. I'm from Emory. I'm a second-year resident. I'd like to share one of my experiences. It's a little bit of a, I guess, a lighter story, but also at the same time a more tumultuous journey. I would like to talk about when I was in medical school, my most rewarding experience to date was essentially in this adolescent transgender clinic where I got to really see patients who were like me. I'm non-binary, my pronouns are they, them, with their supportive parents, kind of being taken care of at this multidisciplinary, truly first in its kind in the region, multidisciplinary clinic. It was just kind of giving you a lot of optimism for LGBTQIA healthcare during that tender age when I was a third-year medical student. However, it only lasted a few years, and by 2021, due to mounting political pressures, it was forced to shut down. So about 150 patients were impacted by this. And here's some live, I guess, real pictures of kind of grassroots community movements and protests to kind of get the clinic back into operation. And in the picture in the right, lower right, I was there. And I just kind of remembered, at this time, just thinking about, like Dr. Mall said, all the division, political climate, and just thinking about the patients and a little bit about myself selfishly, but about the community that I was trying to help in achieving patient-centered care. One of the physicians actually sued the state and got the clinic to resume care again in 2022. And I tell this story to kind of tell you that there's really a lot of hope and a lot of inspiration we can draw from working with physicians, working with the community to help this population and all of the inequalities that are coming out due to these kind of mounting political pressures and inequality.
All right, hi everybody. My name is Michelle Lal. I'm a professor from Emory. Hi, Emory. My pronouns are she, her. But so I have kind of the shortest piece of this talk, but what might be the most important? And it's the why it matters. So number one, it matters because there are people, probably here at this meeting, people in your community, people in our country who don't believe that it does, and who don't believe that we have data as to why it matters. Okay? So if you've ever gone to try to have a negotiation or have a discussion with somebody about an important topic, that's what they want to know, right? Why does it matter to me? And this should matter to everyone. It should matter to all of us, right? We are the front line of healthcare for this country, and that's not changing anytime soon. So this is why it matters. We want to take excellent care of everybody. So I was fortunate enough to be part of a study a couple years ago where we interviewed physicians, both that were faculty level, residents, fellows, and medical students who identified as non-binary or transgender. And I'm not going to read these quotes to you, but see, these are our peers. These are the way they felt when they were with us. We can do better. We have to do better, right? This is not optional. So imagine, these are our peers. How are we making our patients feel? Or other staff that we work with? Probably even worse than what we're looking at here. So again, a few more quotes, but I think too, the other thing I'd like to highlight, and this is a theme in work across areas for individuals who are not majority, who are minoritized, right, is the minority tax. And this is a great emotional burden for folks, right? I've done a lot of work in gender-related research, and I always want to say yes. I always want to say yes if somebody asks me if I can mentor them, if I can help them, if I can give another lecture, if I can sit on another committee, because I want it to be better for my residents over there in 20 years than it is for me right now, right? But it's hard. I got a lot of things on my plate. Sometimes it's really hard to balance these things. So yes, the minority tax is real, but recognize that the people that you're talking to about these issues are also deeply passionate about them. And sometimes that ebb and flow of emotional exhaustion is real. So the answer might be not right now, but that doesn't mean there's not an opportunity for collaboration or discussion later. So everybody in big medicine says this is important, right? So the National Academy of Medicine, one of their 6 domains of quality healthcare is equitable care. Okay, so that is, we want to be providing equitable care to all of our patients, including those who identify as sexual or gender minorities. It came out in the Healthy People 2022, right? So there is now nationally, at least, a little bit of a foothold as to why this is important. This is just a table to highlight that Dr. Mole put together for Rosen's, but there are, in fact, some health disparities that are real. okay? There are studies to show in each of these disease processes that there are differences for gay men, lesbians, and people who identify as bisexual compared to those who identify as straight. So this is real, this is important, and as you start to look at some of these conditions, I would challenge you to think about, is that because these people are stigmatized when they try to seek care? So what happens if you're a 20-year-old woman, maybe you have really severe vaginismus, you only have sex with female partners, you've never had insertive intercourse into your vagina, but you still need a pap smear, right? And so you go and the doctor says, well, every woman should have this every year, like you can do this. Probably not the right way to approach this patient. And what happens 10 years later when they've never had an exam? They come to you in your emergency department with some vague complaint, we put them through the donut of truth, and you find that they have metastatic cervical cancer, right? This is real, and these are things we can control and we can change. So it's important to recognize where these patients might be at greater risk than others. ADIEM says it's important, right? See it there? We have the big red arrow. But this is real. This is important. So when you're having a conversation with somebody and they say to you, well, why does this matter? Well, it matters because the House of Medicine says it does, but so does our boarding organization. So demographics. We don't need to do a show of hands, but there's been a lot of studies to look at what percentage of the population identifies as lesbian, gay, bisexual, trans, or other than heterosexual. So this is a Gallup poll, right, which is a big survey of a whole bunch of folks. And in this survey, they found that the percentage identifying that way was 7.6%. But in other work, we actually see that it's higher. It's closer to 11%, if not a little bit more. And perhaps not surprising to this audience is that those who are out, the demographic is different by age. So I would argue that probably our number is closest to 15% across the population, but as acceptance has changed over time, right? If you're over 65 and you never felt like you could be out, when you turn 70 is probably not the day that you're changing your mind, right? And I don't blame you, right? But with youth, right, we have a very different culture than we did 20 years ago. And so I think we're seeing that this number is going to continue to increase as we create safe spaces and places for people to receive equitable care. So what do we look like in EM? So this is from some work that I did a couple years ago, so 6.3%. So no matter which demographic or percentage you look at, we're still relatively underrepresented in emergency medicine. And certainly a goal is we want to create a more diverse and inclusive workforce is to get that number at least closer to 12%. And why it matters. So this hasn't really been looked at yet in this sphere, but there are numerous studies that show the importance of concordance by gender and by race, ethnicity, and patient care, right? And there's a lot of them. These are just a few of them that are out here, but long story short, if you have gender concordance with your physician as the patient, you have better outcomes. There's some new data about ethnic and racial and cultural concordance, and I think this is the next frontier, right? I imagine there is concordance here as well. And then patient-centered care, right? That's why we're all here. We're here to take good care of patients. We're here to train the next generation of physicians to take good care of patients. And this is work that Dr. Moll did in 2019 looking at residency programs. 94% of residents felt that LGBTQ plus patients deserved equitable care, and 97% were comfortable with working with LGBTQ plus physicians. It does break my heart a little bit that neither of these numbers is 100%, but we're going to get there. If they had done this study 30 years ago, I don't really honestly want to know what the data would have been, but it would have been really poor. So we have, so 30% were against medical school admission for people identifying as LGBTQ+. So we've come a long way, but right, I really don't understand any situation where both of these numbers isn't 100%.
All right, we're going to move on to patient experiences. I'm Elliot Blum. I'm at Emory with Dr. Lal, assistant professor. I go by pronouns he, him. So first I want to talk about history a little bit and more about kind of the history of intolerance towards the LGBTQ population. This is 1969, the Stonewall riots, the Stonewall uprising, pretty well known. There's police brutality targeting LGBTQ population in the Lower East Side of Manhattan. LGBTQ population at the time decided to fight back, and this was a watershed event which helped shape the fight for the LGBTQ rights in the USA. Fast forward about 10 years, the HIV/AIDS epidemic started. In 1980, it was first realized that this was an epidemic, and it wasn't called AIDS until 1983, so that's 3 years where it was called gay-related immune disease, GRID, from 1980 to 1983. So it was highly stigmatized at that point in time, and even if you think about it 40 years later today, it's still a highly stigmatized disease, and so just a significant history of stigmatization against the LGBTQ population. There is an increasing focus, as a society, we are getting a little bit better. We're recognizing disparities, improving access and resources. There's national conferences and more research that is being done. And if you look at from a legislative standpoint, there is some improvements as well. So 2010, everyone knows the Affordable Care Act was signed by Barack Obama, improved access to care in general. 2013, United States versus Windsor ruled that the federal government can no longer discriminate against same-sex married couples for the purposes of determining benefits. So it was the first time that same-sex married couples were recognized by the federal government, which obviously paved the way for 2015 Supreme Court ruled for marriage equality. So same-sex marriage was recognized as same as non-same-sex marriages. And this is important because your employer was giving you health care benefits for your spouse, right? But if you were in a same-sex relationship, your spouse would not be getting health care insurance. So now, 2015, the same-sex couples were awarded the same kind of health care benefits through their significant others' employers. And then 2020, Bostock versus Clayton County, ruled about health insurance, and health insurance could no longer discriminate against sex and gender minorities. They could no longer deny care. They could no longer charge higher premiums because of your sexual identity or gender minority. And then 2022 was the Defense of Marriage Act that was signed by Biden a couple of years ago, recognizing same-sex couples and interracial couples as well. These are a couple of headlines that I found just when doing these talks. I wanted to just read out quickly. 19 states have laws restricting gender-affirming care, some with the possibility of a felony charge. More than 1 in 8 LGBTQ people live in states where doctors can refuse to treat them, and will now allow medical providers to refuse to administer any medical treatment that violates their moral, ethical, or religious beliefs. So as Dr. Lal quickly spoke on, we have a minority population that's increasing in size over time who has healthcare disparities, and now doctors can refuse to treat them possibly, or can possibly get in trouble for treating them as well. So there's been a significant rise of anti-trans legislation as well, right? If you look at 2018, looks like there was 2 bills at that time. Fast forward to this year, 2024, there's already 133 bills that are anti-trans legislation. They've gone up 5-fold, and these are all kind of healthcare-related bills. So it's just been it's been a significant increase in the rise of anti-trans legislation. And then there's healthcare disparities, right? The healthcare access is pretty poor for the LGBTQ population. There's less access to insurance and healthcare services, lower incomes, more live below the poverty line. 8% of LGBTQ needed healthcare outright. 27% of gender nonconforming denied healthcare. Less than 50% of behavioral health facilities offer services to LGBTQ clients. And then gender affirming care is expensive, right? Even with insurance. It can be $120 was the lowest number that we found, but with insurance, $134,000 for gender affirming care that you need is just an extremely, extremely high number, showing that your insurance does not cover the care that you actually need, and highlighting the healthcare disparities faced by this population. This is a map of insurance exclusion. So if you look at the states that are in green, there is dark green, laws that prohibits health insurance discrimination based on sexual orientation and gender identity. Great, 14 states prevent insurance companies from discrimination. If you look at the yellow, which is most of the states, 26 states, there is no law protecting LGBTQ inclusive insurance protections. And then the orange states, which there are only a couple, but still, there's a law that explicitly permits insurers to refuse to cover gender-affirming care. So minority population, healthcare disparities, it's a growing population. They already have issues with the healthcare system and now tack on insurance claims as well. And then I wanted to touch on the minority stress model fairly quickly. You know, everyone deals with circumstances in the environment, leads to general stressors. General stressors can lead to mental health and substance abuse. But for minority populations like sex and gender minorities have increased stress from anything from discrimination, violence, identity concealment, internalized homophobia, and general stressors felt by the environment leads to increased mental health and substance abuse. And I just wanted to put a quick slide about this in it, that in 2019, this is a couple years old, there were 7.6 million LGBTQ adults who had a mental illness and or substance use disorder, which was a 20.5% increase since 2018. So 1 year had a 20.5% increase, citing the minority stress model, and that we can do better by decreasing some of these stressors. And now I'm going to give the slides over to Keem.
Okay. Thank you, Dr. Blum. I think essentially, one, this PowerPoint is very data-driven. As you can see, we have a lot of percentages and stats, but I think all of the things that Dr. Blum was saying and even prior, kind of these accumulating like factors that compound and essentially result in negative patient experiences for LGBTQ plus population compared to their non-LGBTQ plus adults. This is a handful to say, actually. So for example, in this kind of a national KFF study, which is like a non-biased nationwide survey study, asking about previous experiences, negative experiences, I'm sorry, compared of LGBTQ individuals compared to their non-LGBTQ cohort, about whether their healthcare provider believed they were telling the truth, whether they assumed things before asking, and whether they just cared about their concerns. You can see that the numbers are essentially double for the negative experiences. So I guess the question I would ask is, if you had negative experiences in double the amount of your non-queer cohorts, and would you seek care if you really needed it? And I guess the answer in this one qualitative study that's kind of done by Samuels and co, the answer is no. Approximately about 44% of people avoided the ED due to fear of discrimination, long wait times, and negative previous experiences. And the title, I think, kind of says everything needs to say. Sometimes you feel like a freak show. I think Dr. Law actually mentioned one of her studies earlier in the slideshow, and it was something that I read before coming to Emory, and I also agree with the people, the qualitative interviews in that study. You feel, you just feel afraid to come to the ED sometimes, which is very unfortunate. And I think the general idea is that we talked a lot about federal laws, but there is not just individual but systemic factors that have a legal basis, but also vary widely in terms of state laws in the U.S. anyway. So this is going back to Dr. Mall's first story about visitation rights. Like, it wasn't until 2011 when the CMS required covered services to not restrict, limit, or deny visitation privileges based on sexual orientation or gender identity. But if you're not a Medicare or a private institution or in a state that doesn't comply with this, then you could just restrict visitation rights still. And another example of this, I think, is surrogate decision makers. So if you're in Arizona right now practicing, you're about among the 35 states that allow, or I guess recognize same-sex spouses as on equal footing as a heterosexual couple, essentially. But if you're practicing in Georgia, where I practice right now, you're counted as a close friend, which is essentially at the bottom of the list. And then if you're in Texas, for example, which is the lowest tier where I was in medical school, you're not even a close friend. So just kind of imagining what you would do if your spouse was kind of incapacitated from a critical condition. You couldn't make decisions for them. It's all really sad and frustrating, of course, to say the least. Another thing I want to touch on is kind of maybe something you guys don't think about, but parentage in same-sex couples. And just a really quick story, maybe it'll bring some sympathy to light. I think this is Jamie and Krista Contreras in 2015. They essentially had a newborn daughter, 6 days old, wanted a well baby visit, picked a pediatrician out of a handful, you know, as you do if you're parents. I'm not a parent, but I would understand trying to find the best pediatrician for your kid, and then showing up to the pediatrician office and being refused care, essentially, because you were lesbians. And it was legal. This was in Michigan in 2015. And like I said, states' rights and states' laws vary, even if there are federal protections, like with Clayton and Bostock in 2020, where you can't deny care to same-sex couples, you can on a state basis. And about the parentage thing that I was alluding to, if you were basically you were not the person who gave birth to the child, where do you have legal parentage? I've never really thought about this question, but only about 15 states have a functional parent doctrine that says that your same-sex spouse is also the parent of your child, which is kind of crazy. In Arizona, which is the lightest color here, you have to jump through a lot of hoops essentially to prove that you are, for example, the father of the child, which in same-sex couples doesn't even make sense. So I guess the last thing I wanted to say before we move on to the best practices sections led by Dr. Edwards is that just like with laws that kind of tell us about where the inequalities lie, one of the other laws that's kind of present on everybody's minds right now is the Educate Act. And I just wanted to acknowledge and commend SAEM as a conference, as an institution, for issuing a formal opposition to the act, which, if passed, essentially undermines this talk, undermines all the efforts that have come before it, and all the future, what it says here in the statement, future initiatives to foster innovation, advance health equity, and improve health outcomes. Maybe I'm preaching to the choir a little bit, but I think that this is a very important thing that they did, and I want to thank SAEM for that. So I'm going to transition to Dr. Edwards' talk about best practices.
All right, hello there. I am Melissa Edwards. I'm a clinical ultrasound resuscitation fellow at VCU Health in Richmond, Virginia. So I got my crew up here right front and center. Yeah, all right. So I first want to kind of go over the best practices. It's not all doom and gloom. There are things that we can do about this issue. First of all, I want to set the stage, though. I want you to imagine that you're getting ready to board your flight here to Arizona. Maybe it's not your most favorite thing. Hope I'm not giving away too much about Dr. Moll. He is not the most confident flyer. And a lot of us aren't. It can be an anxiety and fear provoking thing. But if you look over to your left on the jet bridge and you see an image like this, think about if you identified as a gay male, how that might make you feel. These people look pretty comfortable, and that might provide some sense of comfort and solace before you board your flight. That's essentially the same kind of environment that we can create for our patients in the emergency department. How we do this, a lot of this is actually translated from use in primary care practices, but there's nothing to say that we can't do this in the emergency department as well. So the first way that we can do this is gender-neutral restrooms. If you look at this image in the left, you'll notice that not only is it inclusive of various genders, but it also has sight adaptation for visually impaired folks who might require Braille, as well as acknowledging patients of other abilities and who might require wheelchairs or other assistive devices to get around. Another thing that we can do past that are LGBTQIA plus friendly symbols. This can be anything as simple as brochures in the waiting room on safe sex practices, HIV or AIDS, hormone therapies, and really the list goes on. Another thing that we can do is visible non-discrimination statements. Actually, the American Medical Association advocates for this and has an example statement on their website that you can use and translate into practice at your institution as well. And the last thing is that we can use artwork. You can be very intentional in your marketing materials to feature ethnically and racially diverse couples, trans patients, and same-sex relationships, much like Delta did in that ad. Past our environment in the waiting room, we can customize our patient intake forms. This is something that is actually adapted from Fenway Health in the Northeast. And notice that not only does it capture language and marital status, but also offers respect to sexual orientation, gender minorities, sex assigned at birth. But ideally, this information would be captured once and really on a need-to-know basis. It's also important to note to patients that this in no way will impact the care that they receive while they're in the department. Further patient identification and data collection things that we can collect, and this is actually part of our Human Rights Campaign's Health Equity Index that seeks to justify and standardize the care that's received by our minority populations, includes options to indicate current gender identity, and if it differs at all from documents that are provided that might be on your identification, insurance, or other documents used in the admissions process. Something else that we can ask and collect data on is asking the sex assigned at birth and capturing a patient's pronouns and displaying them prominently within the electronic health record. Perhaps most difficult of this whole process, though, is how do we teach our employees to capture this information in a sensitive manner and disclose only if it's a needed basis. This also has to be beyond our just generalized LGBTQIA health training that your institution might just have as an introduction. Okay, something else from our patient identification and data collection that we can do is capturing a patient's anatomical or organ inventory. As we saw, there are a number of different disparities that exist within the health of our minority populations, and this is extremely important in preventative health measures. Ideally, this information will only be asked once and can be referenced by clinicians across the health system. Again, we should only be capturing this data or collecting it or asking about it when it's relevant to the patient's chief complaint. We can also indicate a sexual orientation if that information is volunteered from the patient themselves. And as it should hopefully go without saying, is that all of this should be kept confidential and it should be explicitly stated within the visit. Other things to do on our patient identification and data collection is inclusivity of parents beyond the mother and father. As you'll see here on the right, there's a number of different options to indicate maybe children that are raised by grandparents or same-sex couples. And that also includes additional marital or relationship statuses that are inclusive of same-sex marriages as well. Moving past the data collection phase into our encounters with patients, we've all had that foot and mouth moment where we have made relationship assumptions that were vastly incorrect. So how do you avoid that blunder is having the patient introduce and define the relationships that are important to them. How I personally do this is asking patients, who did you bring with you? You might be surprised at the answer, and you might also get some humorous responses that help you relate to your patient better in the encounter. As it should hopefully be obvious, verbalizing respect for the patient and their chosen family, but more importantly is demonstrating that respect as well. And lastly, as we kind of alluded to, allowing patients to define who can visit them. Again, I hope this goes without saying that words matter, and we should utilize language that the patients themselves use, and avoiding making assumptions, acting surprised at some of the responses or behaviors that might be demonstrated in the encounter, and of course, not gossiping about a patient's appearance or their behaviors after the encounter is over. Other things that we can do as physicians to advocate for our patients is maybe one of the easiest, but important things to do is visibility. This is actually a screenshot of our out list at VCU, where providers can, if they are comfortable, display their sexual orientation as well as their pronouns. And this can really be helpful in having patients find commonality with their healthcare providers and find concordant providers that will take care of them. Other things that we can do in physician signals are very simple: badge buddies. Pronouns, these are an example of some of the cards that we actually have at VCU that were handed out to our residents as well as other staff if they're interested in wearing them, as well as badge reels. This was something that was very personally important to me, as there was a nurse at VCU who made a bunch of badge reels, and my attending actually gave me one as an intern. And it was a simple gesture, but it made me feel included and that I was in the right place for residency. Hospital-wide, something that you can do are observe LGBTQIA plus events such as World AIDS Day, Pride Day, and Trans Day of Remembrance. And lastly, in terms of hospital-associated things, are affinity groups. This can allow you to have advocates within the space that share a common goal, as well as have a social outlet to have like-minded individuals to have fun for once outside the hospital. All right. Hopefully this should go without saying, but diversity of staff, a diverse workforce can and should reflect the diversity of patients we encounter in the ED. This is actually part of the Joint Commission's LGBTQ field guide that explicitly notes that a hospital can only provide welcoming and competent care through a workforce that is prepared to do so. So the first step in delivering LGBTQ plus patient-centered care is to take steps to provide equitable treatment and inclusion for its employees. Again, this is part of your Health Equity Index scored questions, which includes, does your employment non-discrimination policy include the term sexual orientation and the term gender identity or expression? And is your employment non-discrimination policy communicated publicly in at least one way? We also have to be extremely intentional about this. Presumably, if your staff is more comfortable in the workplace, it's going to lead to increased productivity, job satisfaction, recruitment of talented individuals, and importantly, retainment of those individuals as well. We talked about some of the benefits as well. Those need to be equitable. Offering healthcare benefits to domestic partners of benefits-eligible employees, as well as family formation benefits, FMLA equivalent benefits to take care of domestic partners, inclusive paid family leave that even goes down to children of domestic partners regardless of biological or adoptive status, as well as bereavement leave. This is perhaps the most important part of our best practices in education. Our quality of care delivered to LGBTQIA plus population will be measured by the least trained staff person. So it has to include all of our team members, anyone from registration all the way up to our physicians and all of the staff in between. Now, this should include cultural sensitivity, language guidelines, comfort in discussing sexual practices, gender orientation, and the list goes on. But this requires continued engagement. This cannot be a one-and-done training. As we know in the ED, there's a large amount of staff turnover, and there's also a constant evolution of affirming LGBTQIA plus language. So consistency and adaptation are keys to effective care. Our first step to recognizing these deficiencies is recognizing that there may be an issue. And by you being here at this talk, that's also a great step as well. Now, sadly, why this matters, unless specifically addressed, their bias exists even in our medical students. This is a study of heterosexual first-year students from U.S. medical schools back in 2010, measuring their attitudes towards gay and lesbian people. I want you to see that nearly half of respondents expressed at least some explicit bias towards gay and lesbian individuals, whereas 80% expressed at least some implicit bias. Again, why this matters is there was another systemic review in 2019, the BMC journal, that identified that bias-focused interventions are effective. Things like experiential learning, intergroup contact, are all very, very important in addressing explicit bias. However, implicit bias is difficult to change. We really have to address these issues early so that they don't continue throughout training. Now, sadly, we're not always doing that. In terms of our health education that we're offering to students, medical students receive less than 5 hours of instruction as published in JAMA in 2011. Sadly, this does not change across residency, whereas in 26% in 2013 of programs were giving some sort of LGBTQIA health education. We got a little bit better in 2020 with 75% of programs having some sort of education, but you notice here that median is only 2 hours. We're not doing much better as faculty either. In an academic center, you might see about 16% of academic clinicians are receiving any sort of instruction. How do we change it? Well, again, by you being here at the talk, it's a great first step, but all of this starts with executive sponsorship and leadership. Leaders should have a plan in place to respond to and address microaggressions, whether that be through patients or staff. And then we have to continue our support of research and education so that we can have future leaders in this space and address any sort of disparities in the future. And with that, I'll give it back to Dr. Moll.
Solo applause, well done. All right, so in summary, just to kind of wrap it up, and hopefully you'll have an opportunity to share some questions and maybe some best practices and experiences those comfortable sharing. Bottom line is, respecting a patient's identities is patient-centered care, period. Decision affects inclusion, division that we're experiencing now affects inclusion and belonging, but not being. People are who they are, and it's whether they're comfortable feeling like they're belonging. And understanding the unique need and disparities of the LGBTQIA plus population is really important, as is appreciating patient experiences and perspectives, because ultimately we want this all to lead to better care for our patients and thus better outcomes. So finally, visibility in treatment environment is essential for belonging. That's both auditory, visual, all those type of things that you may hear, because signs can either be welcoming or isolating. So I would ask, when somebody comes to the emergency department that's a gender or sexual minority person, and they say, is it okay for me to be here for my medical emergency, that hopefully at your shop they answer yes. Finally, with all the laws, with all the rhetoric, with all the division, Harvey Milk from back in the 70s reminds us it takes no compromise to give people their rights. It takes no money to respect the individual. It takes no political deal to give people freedom. And it takes no survey to remove repression. And with that, you can scan the QR code. It will get you to all our email addresses. It'll give you multiple resources. And if you have any questions, feel free.
Thank you guys so much for that talk. We got a presentation recently about how our board exams for EM are about to change and include more patient-centered care testing. I personally haven't looked deeply into whether inclusion or inclusive language and ensuring that we are using the full scope of what patient-centered care means in our practice and being tested in a way that supports that. Are there conversations being had about how we're gonna include this into the new board certification? Do we know anything about that? And how can we support that inclusion in those exams?
I assume you're talking about the new ADIEM oral examination? So I would encourage all of you to look, if you are not yet board certified, at what ADIEM has on their website. They have a pretty inclusive reference list. A similar in situ examination has been conducted in other specialties at the board level, so there are some references there. They have an FAQ and some other information that does remain a bit on the vague side. However, I do know that inclusive language was a priority for ADIEM in the generation of this new model, and has been, at least for the last 5 years, in revision of current exam questions, whether they're for the certifying exam or the oral exam. So it is something that ADIEM is acutely aware of, and I do think has been working to make changes there.
And just to add to it, I mean, I'm a board examiner, you're a board examiner. I mean, so we're not speaking for ADIEM per se as far as the boards, but I can tell you that inclusion language does exist currently in some of the formats for testing. And the intentionality is to do even more.
Hi, just a quick question about the visibility and optics component that you discussed and how it relates to kind of the disparity in education. It's, I imagine, pretty easy for a lot of shops to have really good signage and visibility and sort of communications that encourage people and confirm that people should feel safe here, but if the staff and faculty and everyone isn't quite up to that par, you're almost gonna sharing a false bill of goods. And I thought the education slides about how little continuing education on queer health there was pretty alarming. So how do we kind of get that buy-in so that we're not creating a false bill of goods and not sort of breaking down more trust?
I think that's a really difficult question to answer because truth be told is that, like I said, a lot of this really does start with executive sponsorship. So really all of this has to trickle down from the top. So the buy-in can start at the top and hopefully will grow as time goes on. I know specifically at VCU, we have a chair that's very aware of these issues and addresses them regularly, goes so far as to wear his pin on shift. But really, just addressing and recognizing that there is an issue is kind of the first step. I don't necessarily know that you can always change opinions. As you can kind of see, our nation can be quite divided at times. But really, when it comes down to it, it has to come from within and at the top of how we address these issues.
I think you also have to remember this is a journey, not a destination, as much as I'd like to make it a destination sooner rather than later. And, you know, again, looking back to the early 2010s, when this was not part of the EM model of clinical practice, when you look back at the fact that nobody was teaching this in undergraduate medical education, and actually there was a paper that just came out that was kind of a redo of the Oberlin article in 2011, that's gotten much better too. So we're moving the needle, and we're moving the bar. However, is that enough? No. We need to do more because, as Dr. Edwards said, I mean, you have to have everybody on board with this because if you have somebody come in that, you know, is rude or is, you know, inflicting their biases, you know, explicitly up front, you know, you're kind of lost right there, right? So we all have to kind of be a team working together.
Yeah, I mean, I think the other thing to remember too is that this is a place where you know, I think a majority of our physicians signal on their badge in some way that they are an advocate or an identifier as well. And, you know, I've had, right, especially as the attending, you have experiences where the patient is like, this person who also was involved in my care said or did this. And I think we have the opportunity to, one, own that for the health system, right? To say, I am terribly sorry that that was your experience here. I hope that's not been your experience with me. And how can I help make the rest of your visit with us better, safer, whatever word you want to use. And yes, it takes more of you extending that way, but maybe that is the difference that the patient needs on that visit to come back next time. Right? I mean, we can only control our own behavior, and as Melissa said, it has to come from the top. But there are always going to be people who are unwilling to change, right? But if I think we have enough of a cohort that are able to show support and advocate for our patients, that we'll get there, right? It's a journey. It's going to take time, but sometimes it's that extra small moment with the patient that allows them to come back next time and maybe feel a little bit safer in doing so.
Hi, so I had a question. I've definitely, you know, encountered, I think many of us have, kind of in the moment times in the ER when you're having like staff members or preceptors or attendings make comments that are like not appropriate. Do you have any advice on how to push back against that in the moment? Because I have not really had success in this area.
I think I have a great answer to this, and has to do with allyship. A lot of the times you don't want to, or you can't, or you feel disempowered to fight and stand up for yourself. But if somebody else on your side is kind of advocating on your behalf and pointing out things that they see, it doesn't have to be an accusatory or even a negative thing. You just, what do you mean by that? Or say more about what you mean, things of the sort, to kind of just probes the question about what these comments are really trying to say and what their biases are. But somebody else doing it will really kind of alleviate a lot of that pressure that you feel to do that until you can, of course. And of course, you can do it by yourself. But I think allyship has been one of the greatest things in like my really short career so far, of people just kind of empowering each other around the spaces around me to kind of help each other out and make everybody better, even when I'm not around. So I think that's like the most important thing that I've found. Does anybody else have anything?
Yeah, I mean, you know, responding to these situations is like an entire workshop in and of itself. It's very hard, and particularly if you are a student or a trainee. But I think, like they said, what did you mean by that? You know, there are some people that will take the approach of like taking the onus on them. Like, I don't understand why you said that. I don't understand why that's relevant. Which we could argue taking the onus on you, whether that's an effective approach or not. But typically in these situations, as soon as you say something to someone, they become very, very defensive, and the conversation is done before it's even started, right? So that is one strategy that potentially will allow for an actual dialogue. The other thing is sometimes the moment is maybe not the right time. And particularly if you're having an encounter with another faculty member, you know, maybe it is, we need to readdress this like a week from now, you know, but I do think the follow-up is important. I think there are certain situations, if it's at a bedside in front of a patient, where there is a time that it has to be called out, like there really should be zero tolerance. But I can say that as an attending much more easily than Keem can, right? So there is an art to it, and there's no one-size-fits-all answer, unfortunately. And it's one of those things that if you were the victim of the microaggression or the macroaggression or the transphobia or whatever it was directly, it's okay to not want to fight the fight every single time too. Like, it's okay to say that today is a day I'm going to make my fight, tomorrow's a day that I'm not. And like, don't have guilt about that, because it's a lot. Those scenarios are emotionally taxing.
I mean, the ultimate thing is it's a very uncomfortable situation, and how do you make that comfortable, right? And I think you just have to sometimes accept you can't, but there's an opportunity for you to be an educator too, and there's an opportunity to kind of take somebody aside. So you have to think about where the best way to address it, where's the best format to address it, but the key thing is to address it.
I also think, just as Keem mentioned, making sure that you have allies within your department, I think is essential. Somebody, you know, you might not want to address it in the moment, you might not feel comfortable, but if you have an ally, especially who's an attending in the department who you can speak to about these issues, I think, at least as an ally myself and as an attending who's heard about issues like that, it's a lot easier for me to go approach somebody else who is one of my peers, as opposed to making a resident or medical student go approach them. And so I think identifying allies at your institution, having these conversations, making sure you feel comfortable talking to them, I think is super important. So
Thank you all for coming.
Thank you.
Thank you.